Hello, my name is Greg Moorlock. I'm an Associate Professor at Warwick Medical School at the University of Warwick in the United Kingdom. Today I'm going to be presenting some work on behalf of me and a co-author, Professor Heather Draper, also University of Warwick, and I'm going to talk about how we can add nuance to organ donation decisions. I'm going to argue that there are good ethical reasons why we should do this, and I'm going to present a proposal in how we could actually achieve this, suggesting that there are some serious ethical advantages to doing so. What I'm going to talk about today will have an emphasis on UK practice and policy, but I'm confident that similar issues will be encountered internationally. So although I may use some UK specific terminology, I think that the underlying issues will have relevance elsewhere too. In recent years, developments such as pre-mortem interventions to facilitate organ donation after circulatory death, normothermic regional perfusion and ex situ machine perfusion have significantly changed what happens to donors and their organs. While the processes associated with donation have become more complex, the opportunities to indicate a willingness to become donors have been simplified. In the United Kingdom, most evolved nations, so England, Wales and Scotland, have already moved to systems of deemed consent, and Northern Ireland looks set to follow reasonably soon. An absence of objection can now be regarded as a willingness to donate. Maintaining simplicity in organ donation systems is generally desirable, insofar as presenting the public with numerous complex options may deter them from making decisions, or potentially create confusion and maybe an unwillingness to donate. But this mismatch between the simplicity of the donation registration system and complexity of donation processes has some quite profound ethical implications. So in this talk, I'm going to argue that these ethical implications are undesirable and that they potentially lead to patients being treated in ways that are not clearly in accordance with their best interests or their wishes about donation. So we're going to propose a way forward, similar to the existing respect form that's used in the United Kingdom in relation to end-of-life care planning, which would provide patients with the opportunity to express greater nuance and precision in relation to their organ donation wishes. We argue that if done appropriately, this need not be considered to increase complexity in the donation registration system and would increase the likelihood of patients' wishes being accurately respected, thereby also reducing some challenges faced by families and clinicians at the time of donation. Transplantation has always embraced new developments, and technology to support and facilitate organ donation has significantly advanced in recent years. Dying, death and organ retrieval inevitably cause injury to organs, so technological approaches to minimising or even reversing aspects of this damage are of benefit to transplantation. Ex vivo machine perfusion, where organs are connected to machines that flow fluids through them, allow more time to assess the function of the organ. In some cases, it permits the organ to recondition, so that some organs that were previously considered higher risk for recipients, or simply untransplantable, may now be transplanted with greater confidence. In situ normothermic regional perfusion allows for oxygenated body temperature blood to be perfused through organs while still in the donor's body after death has occurred. Measures are implemented to ensure that this perfusion does not risk restoring any limited function to the heart or brain, and the process typically lasts around 2 hours. The process improves transplant outcomes for the eventual recipients of the organs. These technological developments may be used in conjunction with more routine interventions prior to death that are necessary to facilitate or optimize donation and transplantation. This has particularly been the case for DCD donors and has been the subject of much ethical and legal discussion. Pre-mortem interventions currently tend to be limited to relatively minor things, such as additional blood tests or measures to stabilise a dying patient's condition prior to withdrawing life-sustaining treatment. But they could potentially include more involved interventions aimed at optimising organ quality while the patient is alive. The UK-wide strategy for organ donation and transplantation identified key areas for action, including aiming for optimal organ utilisation in every organ group, benefiting from new technologies and techniques, and to build a pioneering culture of research and innovation in donation and transplantation in the UK. Recent research has highlighted issues with consent in relation to interventional research with organ donors, so it's important to give consideration to how some of these issues may be resolved. It's no longer the case that organ donation is a relatively linear process of organs being retrieved from the dead donor, stored and transported at a low temperature, and then transplanted into a recipient. Organs may now spend extended periods of time inside the dead patient, or may be connected to machines for days prior to transplantation, and some actions to facilitate or optimize donation may take place while the donor and patient is still alive. To add complexity to this, some aspects of these developments remain relatively experimental and involve elements of research. All of these factors combine to make for a potentially complex set of decisions at a time when the patient is unlikely to be able to express their wishes. It is surprising then that there is currently little opportunity for patients to formally record their wishes in relation to these types of decisions. We believe that there are some significant ethical implications of this situation. The principle of respect for autonomy is challenging to apply to dead people because posthumous wrongs or harms are difficult to convincingly explain, but respect for individuals' wishes is nonetheless built into organ donation systems. It's widely considered that to be ethical, organ donation should be voluntary. This is a feature of organ donation systems worldwide, whether opt-in, opt-out, or even reciprocity-based like that seen in Israel. Where forced organ donation has occurred, such as in China, it has been almost universally condemned. We will take as our starting point that whether or not organ donation proceeds, if it's clinically appropriate, should be in alignment with the patient's wishes. UK residents are able to express their wishes about organ donation in different ways. In nations with deemed consent systems, someone is presumed willing to donate unless they register an objection. Willing donors therefore need do nothing to indicate willingness. There does remain an option, however, for willing donors to positively express their wishes via opting in. And in Northern Ireland, which currently doesn't have a system of deemed consent, this is how all potential donors formally record their wishes. This provides an opportunity to express some nuance in one's wishes, as one can select precisely which organs one would be willing to donate. People are given control, therefore, over whether they donate and what they donate. But there is no opportunity to record wishes in relation to how one donates, nor the strength of those wishes. Because the organ donation process has become more complex, it's not obvious that a willingness to donate some or all of one's organs necessarily translates into a willingness to undergo, or for one's organs to undergo, all of the steps and interventions that may now or in future be a part of donation. Hence, there is a danger that organ donation may go ahead in ways that are not in accordance with the donor's wishes. For example, a potential donor may be broadly in favour of donation, but uncomfortable with the idea of their organs being hooked up to a machine for days, or they may be uncomfortable with the idea of blood flow returning to their organs in their own body posthumously. If it is important to respect a patient's wishes when it comes to whether their organs are donated, their wishes for how their organs are donated should arguably also be respected. Patient wishes are even more important for donation after circulatory death, or DCD donation. Potential DCD donors are alive at the time that many decisions about organ donation are made, but in most cases the patient lacks capacity to make decisions, which brings them under the protection of the various mental capacity legislation within the UK. Decisions must therefore be made in the best interests of the patient. Sometimes this is referred to in terms of overall benefit for the patient. Determining the best interests of a patient when it comes to organ donation is difficult. The fact that someone has not opted out of organ donation does not necessarily mean that they would be willing to undergo the pre-mortem interventions required to facilitate donation. The fact that someone has opted into organ donation may give stronger evidence of the patient's wish to become a donor, but doesn't actually give evidence of the strength of the patient's wish to donate. Application of relevant legislation to DCD donation has clarified that donation can be in a patient's best interests if that patient wanted to donate, and that treatment to facilitate donation may also be in that patient's best interests. But to accurately determine this, a doctor would need to know about the patient's other interests and how they would weigh these against their wish to become a donor. For instance, a patient may wish to donate, but not if it were to distress their loved ones. Or a patient may wish to donate, but not if it required a significant delay in withdrawing life-sustaining treatment, or if it involved other risks. The lack of a routine, formal opportunity for potential donors to consider and then express the strength of their wish to become an organ donor and to describe other countervailing considerations means that decisions about best interests are sometimes essentially guesswork. Doubtless, many donors are willing for their donations to be facilitated by new technology to further push the boundaries of transplantation, but it would be wrong to assume this of all donors. Some donors may perceive more experimental interventions to be riskier and instead wish for their organs to be used in lower risk ways. Some donors may fully support groundbreaking research and wish for their organs to be used in its furtherance, even if it means that their organs may ultimately not be transplantable. Donors may have different senses of what costs to their family are outweighed by successful transplantations. But without a routine opportunity for potential donors to consider and express their preferences in relation to donation research, respect for patient autonomy is potentially undermined, and we may create additional challenges for this type of research. Many UK institutions have implemented something known as the RESPECT process. This stands for Recommended Summary Plan for Emergency Care and Treatment. This is a particular approach which includes a form, known as the RESPECT form, and a process via which it is completed. And this provides personalised recommendations about a person's future treatment and care when they are unable to make their own choices. The brief form includes the option to state things such as what I most value and what I fear or wish to avoid. There is a scale upon which one can mark one's position between living as long as possible matters most to me and quality of life and comfort matters most to me, followed by a section where a clinician can recommend things such as prioritise extending life, or balance extending life with comfort and valued outcomes, or prioritise comfort. The details of the form are not actually crucial for this discussion, other than to give a sense of what a form such as this can potentially capture. Interestingly, the RESPECT form gives no specific consideration to organ donation, although we actually think it should do, and as a consequence could hinder donation if some of its content was in tension with donation processes. The exclusion of organ donation may be deliberate rather than an oversight, given that the RESPECT forms are often used for patients with terminal or degenerative conditions, which may prohibit much donation anyway, but nonetheless it's a notable omission. So we propose an equivalent to the RESPECT form explicitly for the purposes of providing additional information about a patient's organ donation wishes. An appropriately designed form would give patients who use it an opportunity to express how their wish to donate their organs should be balanced against other potentially competing wishes, would allow patients to express which procedures pre and post-death they would be willing to undergo, and express their preferences in relation to interventional research. The form could be an optional extra for patients when they register an organ donation decision online, and simple for patients to update should their wishes change. Given the increasing complexity of organ procurement processes, having such a form for the purposes of organ donation could offer some significant benefits. There are 4 key benefits to our proposal. First, our proposal promotes patient autonomy. Second, it is more likely to result in decisions being made that accurately reflect the patient's best interests. Third, it presents a clearer situation to relatives and alleviates some of the decision-making burden that might otherwise lie upon them. And finally, it provides clarity for clinicians so that they can be confident that they are making the right decisions. The proposed form would promote autonomy in 2 respects. First, it creates a wider domain of decisions over which patients can exercise choice. Potential donors would be able to specify what they would be willing or would be willing to permit their organs to undergo in order to achieve successful donation. Second, it increases opportunities to educate potential donors about donation, thereby helping them to make more informed choices. An online form could be accompanied by interactive materials explaining the pros and cons of the various technological options that may now accompany donation. Completing the form could remain optional, but could help interested patients to make more nuanced and informed choices about what happens at the end of their lives. Without contrary evidence, we should not assume that the public knows what donation may involve, or what research and innovation may hold for the future of transplantation. Not everybody would wish to know more about the intricacies of donation, and some people may be willing to give a blanket yes or no to everything involved in donation. But the increasingly complex nature of donation, with components that patients may or may not wish to be involved with, suggests that giving patients additional information and control will maximise opportunities to both respect and promote autonomous decision making. Most importantly, Our proposed form would give potential donors an opportunity to clearly express the importance of organ donation to them and which burdens they are willing to shoulder to become an organ donor. As discussed, someone not opting out of organ donation may be considered evidence of a wish to become a donor. Someone opting into organ donation would also be evidence of a wish to become a donor. Assuming that somebody opting in has a stronger desire than someone who has simply not opted out would reflect flawed reasoning, however. Opting in arguably gives stronger evidence of a desire to donate, but says nothing about the strength of the desire or how this should be weighed against other factors. Simply knowing that someone wanted to become an organ donor does not provide much guidance when determining whether organ donation is in their best interests. All it provides is one known wish amongst potential other known and unknown wishes. Without knowing the weight afforded to each of these wishes by the patient, establishing whether donation is in their best interests, without further discussion with family members or making fairly heroic assumptions, is not really possible. A well-designed form would allow potential donors to express the relative value they afford to their donation wishes, thereby increasing the likelihood of decisions being made that accurately reflect these. The advantages are not restricted to people who could become organ donors. A key message of recent organ donation campaigns in the UK has been to communicate one's donation decision with one's relatives. Partly this is because it increases the likelihood of one's decision being respected, but it has also been suggested that it makes the situation for one's relatives easier if they have a clear sense of what one wanted. Our proposed form would make explicit the patient's wishes in a way that is likely to be difficult to achieve via an informal conversation over the dinner table. Other people, notably David Shaw, have suggested other things, such as a proposed video personalised organ donation directive to inform relatives of one's willingness to donate. But our proposal goes beyond this by providing nuance and value to one's potentially conflicting wishes. This benefit also extends to the staff involved in organ donation. Having additional information to guide their decisions should increase their confidence that they are making the right decisions for that particular patient. Our proposal does, however, have potential downsides. A key feature of the Respect form is that it has accompanying processes. The plan recorded on the form is reached via discussions between a patient and a healthcare team and can be an important part of advanced care planning. Implementing a similar approach for organ donation would be resource intensive, and it is not obvious when would be an appropriate time for such discussions to be had. Although there may be arguments in favour of a wider use of Respect forms, they are generally used with patients approaching the end of their lives or who are foreseeably anticipated to risk losing capacity. While equivalent processes for our proposed form may offer some advantages, we suggest that they are not strictly necessary. Online materials could serve a similar purpose, and a form without processes is probably preferable to no form at all. A further potential disadvantage is that such a form could potentially become outdated should a patient's wishes change, and therefore potentially hinder respect for their autonomy. It's currently the case, however, that a person's organ donor register status may not reflect their latest wishes, and nor might their family's perceptions. While there is the potential for such a form to become outdated, it would at least provide a starting point and an additional snapshot of concrete information about the patient's wishes to aid discussions and decisions. There are also some putative reasons why scope for patients to have additional input over the specifics of organ donation is not already facilitated, so maybe some of these decisions are considered clinical decisions and patient input is not required. Or providing people with more information or too much choice about organ donation will discourage donation, or perhaps giving patients additional choice would require bespoke donation processes for each patient. Now, while it's true that decisions about whether, for instance, ex situ machine perfusion is appropriate for a donated liver is largely a clinical decision, it also remains true that it's something that a potential donor may feel that they have a stake in, and something that might influence their willingness to donate. Someone feeling that they should have input into a decision does not mean that they should have input, of course, but if that decision has a substantive input upon another decision within their legitimate control, then their views do gain some significance. For example, a potential donor may be willing to donate, but only if ex situ machine perfusion is not used. Although this could be construed as conditional donation and therefore fall into some murky ethical territory that the UK has dealt with previously, it is not significantly different from someone agreeing to donate some but not all organs. So whether giving people more information or too much choice would discourage them from donating is an empirical question, but it does not speak decisively against our proposal. If giving patients more information leads them to make different decisions, then arguably they should be provided with that information to make a sufficiently autonomous decision in the first place. If providing patients with too much choice discourages them from donating, in that they may be confused about the options and that this then dissuades them, then the choices could be presented differently or in more understandable ways. Given our proposed form is an optional extra for those wishing to record more nuanced wishes, it seems unlikely that those with no interest in these options would pay much attention to it anyway. Finally, it's plausible that having more precise information about patients' wishes could make the donation process more complex. We accept that. Rather than a consistently applied process, each patient may require a bespoke process based upon the individual factors and processes that they would or would not be willing to accept. This may add complexity and may require additional planning. If a patient is not willing for their options to undergo machine perfusion further down the line, then different recipients may be more appropriate for those organs, for example. But this is not really a compelling reason to oppose our suggestions. Clinical differences already dictate individualised approaches to donation, so our suggestion may not make things more complex than they already are, and greater clarity of the patient's wishes may aid navigating this complexity. If it's important to respect patients' wishes at the end of life, then the system should really adapt to accommodate this, rather than balking at extra complexity. So, to conclude, we have argued that a form similar to the RESPECT form that's currently used in the UK for end-of-life care planning, but specifically for the purposes of organ donation, may offer benefits to potential organ donors, their families, and medical staff involved in donation. A simple yes or no to cover all aspects of donation may be sufficient for some patients, but there are practical and ethical imperatives to offering patients opportunity to record more complex preferences. It is perverse that, as organ donation and procurement has become more complex and multi-staged, the means of expressing one's wishes has become more simplistic via opt-out legislation. Our proposal would give those who wish to make more nuanced decisions the opportunity to do so, and would also provide a vital opportunity to establish not just evidence of a wish to donate, but the strength of that wish relative to other considerations. This latter aspect has been given inadequate consideration in key guidance, potentially resulting in decisions being made that are not consistent with a patient's best interests. So that is our proposal, and we think it is relatively straightforward. There is nothing that is tremendously magical or complicated about it, but it does seem to offer some significant potential benefits, certainly for the way that things are currently working in the United Kingdom. We think it's surprising that no such system like this is currently being implemented. We would, however, genuinely welcome any comments or suggestions on this. I'm always very happy to discuss any issues in relation to donation and transplantation. So this isn't just a token gesture. If you have any questions or comments in relation to this paper, I would genuinely be very interested in hearing them. So thank you very much for your time. If you've made it this far, I hope it has been interesting for you. And yeah, please do feel free to send me any questions or comments.